Small intestine. The small intestine forms a large aspect of the gastrointestinal tract. It is the primary site of absorption of nutrients and minerals gotten from food that has undergone digestion. Let's talk about the gross anatomy of the small intestine. It spans the entire abdomen and runs from the right upper quadrant to the right lower quadrant, then ending at the left lower quadrant. The small intestine is said to extend from the pylorus of the stomach. So it starts off as the duodenum at the pylorus of the stomach and ends all the way at the ileocecal junction as the ileum, where it meets and eventually transits to become the large intestine. In terms of the dimensions of the small intestine, in the adult human male, it measures about 6.9 meters, which amounts to about 22 feet 8 inches. In the female, it's about 7.1 meters, also amounting to about 23 feet 4 inches. And the small intestine tends to be distinguished from the large intestine in terms of its width. So in terms of its width, it is smaller compared to the large intestine. Aside that, there are some important features that we see on the large intestine that we don't see on the small intestine. So features like the presence of Retinia coli, obstructions and appendices, epiploic hair. These are features we find on the large intestine that we don't see on the small intestine. And one other thing to note about the small intestine is the fact that it tends to have a very wide surface area. We'll talk about that when we talk about the histology, but the surface area of the small intestine tends to be an average of about 30 square meters in dimensions. There are three major parts of the small intestine, of which we'll be talking about in the slides to come. This includes the duodenum. That's the first part of the small intestine, the part that is continuous with the stomach. That's the area shown in green. Then we have the jejunum. The jejunum is the aspect shown in blue. And then finally, we have the ileum. The ileum is the longest part of the small intestine, and it is the part that tends to terminate by becoming the large intestine. Let's start with the duodenum. Duodenum is the shortest, widest, and most fixed part of the small intestine. It is the continuation of the stomach at the pylorus, so it extends from the pyloric end of the stomach, and then it ends at the jejunal flexure, or the jejunal flexure, where the jejunum would automatically continue. In terms of shape, it is described as a C-shaped or horse-shaped structure, and that measures approximately 25 centimeters in length. So in shape, it's a C-shape. In length, it's about 25 centimeters in length. And that C-shaped configuration of the duodenum tends to occur due to the fact that it is related to the head of pancreas. So the C-shaped curve tends to be around the head of the pancreas, and of which it has a very unique relationship with when we talk about the connection between the pancreas and the duodenum. And finally, the duodenum tends to be described as a largely retroperitoneal organ, except at its end, so at the proximal end and a bit of the distal end, it tends to be described as intraperitoneal. The duodenum is divided into four major parts. This includes the first part of the duodenum, known as the superior part, the second part of the duodenum, known as the descending part, the third part of the duodenum, known as the horizontal part, and then finally the fourth part of the duodenum, known as the ascending part. Each of these tends to take different dimensions of the entire 25 centimeters length of the duodenum. Let's start with the first part of the duodenum. This part is known as the superior part. It is also called the duodenal cap or the duodenal pulp, and it measures about 5 centimeters out of the 25 centimeters of the length of the duodenum. This 5 centimeters also translates to about 2 inches in length. So if you take the first part of the duodenum, half of it, the proximal half of it, or proximal 2.5 centimeters, is said to be entirely intraperitoneal. And then the distal 2.5 centimeters of the duodenum is aspect that is retroperitoneal, and is retroperitoneal with the rest of the duodenum. The first part of the duodenum lies anterior to the first lumbar vertebrae. And just for you to quickly remember, the part that is intraperitoneal tends to be the part that tends to be in relation to or connected to the undersurface of the liver through the hepatoduodenal ligament. So that hepatoduodenal ligament that connects the duodenum to the liver tends to be connected through the first or proximal 2.5 centimeters, the part that is intraperitoneal. This area tends to mark the site or tends to be the commonest site for duodenal ulceration. So duodenal ulcers, what we call peptic ulcer, typically tends to occur at that proximal 2.5 centimeters of the duodenum. Let's move on to the second part of the duodenum known as the descending part. This part of the duodenum tends to measure about 7.5 centimeters or 3 inches in length. It is one of the longest aspects of the duodenum. It is entirely retroperitoneal. That's in contrast to the first part of the duodenum, which has portions of it being intraperitoneal and then portions being retroperitoneal. For the second part of the duodenum, a large chunk of it or the entire aspect of it is retroperitoneal. Because it is descending, it tends to begin from the first lumbar vertebrae and descend down all the way to the third lumbar vertebrae. It lies beside the head of the pancreas, so it is the portion of the duodenum that forms that C-shaped pattern that I mentioned. You can see the vertical aspect of the C-shaped curve that the duodenum tends to form. That vertical aspect is the second part of the duodenum, and that's the area that is usually in relation to the pancreas. So the head of the pancreas should sit medial to the second part of the duodenum, as I'm outlining in my image here. It receives the ampulla of Vater. So remember, the ampulla of Vater is a duct that tends to drain the bile duct and the major pancreatic duct. So that ampulla of Vater tends to end at the second part of the duodenum. It ends by forming an opening within the lumen of the second part of the duodenum. This opening is known as the major duodenal papilla. So the major duodenal papilla tends to be the exit site of the ampulla of Vater. Above it is a smaller opening point known as the minor duodenal papilla, and that serves as the exit or the exit point for the accessory pancreatic duct. So each of those pancreatic duct tends to end within the duodenum. One of them tends to unite with the bile duct to form the ampulla of Vater, and the other just ends individually at the duodenum. The third part of the duodenum is the horizontal portion. It is the longest part of the duodenum. It measures about 10 centimeters or about 4 inches in length, and it tends to be also retroperitoneal, entirely retroperitoneal. It crosses the third lumbar vertebrae and is found anterior to it and lies just below the Usinate process of the pancreas. So if it's the pancreas, as I'm drawing here, the Usinate process is that curved portion of the head of the pancreas, and below that curved portion of the pancreas is the third part of the duodenum. So it lies below the Usinate process of the pancreas. The final part of the duodenum is the fourth part of the duodenum, is also known as the ascending portion. It measures about 2.5 centimeters. It is retroperitoneal as well, and it tends to ascend from the third lumbar vertebrae all the way up to the first lumbar vertebrae. Is the shortest part of the entire duodenum, and it tends to be continuous with the jejunum at the duodenojejunal flexure. So the duodenal flexure tends to be just this portion where the fourth part is continuous with the jejunum. Usually at that point, there's a ligament that tends to anchor the duodenojejunal flexure to the posterior abdominal wall, and that ligament is known as the ligament of Treat. Ligament is clinically significant because it tends to become the landmark for distinguishing um, upper GI from lower GI bleeding. So gastrointestinal bleedings occurring in the upper part of the gastrointestinal tract tend to occur above the ligament of Treat, so from the fourth part of the duodenum all the way up to the mouth, whereas the gastrointestinal bleeding that we consider as lower gastrointestinal bleeding tends to occur from below the ligament of Treat, that is from the jejunum all the way down to the inner canal. Let's move on to the jejunum. The jejunum is the second part of the small intestine. It is intraperitoneal. It forms about 2/5 of the entire small intestine and extends from the jejunal flexure, which is the end of the duodenum, all the way to the ileum. It tends to occupy largely the left upper quadrant of the abdomen, and it measures about 2.5 centimeters in length. It is a fibromuscular tube, just like the rest of the small intestine, and is involved in the process of uh, absorption, it has a fan-shaped mesentery that tends to anchor it to the posterior abdominal wall. So just like the ileum and a part of the duodenum, the jejunum has a mesentery that tends to anchor it. That mesentery makes it an intraperitoneal organ. Finally, let's talk about the ileum. The ileum is the part of the small intestine. It is also intraperitoneal, meaning it's going to also contain a mesentery that anchors it to the posterior abdominal wall. It forms about the fifth of the entire small intestine. It occupies the right lower quadrant of the abdomen and extends from the jejunum to the ileocecal junction, which is the end point of the small intestine. The ileum measures about 3.5 meters in length, so it's the longest part of the entire small intestine, the duodenum being the shortest, and the ileum being the longest. It is also a fibromuscular tube, and it has that fan-shaped mesentery I mentioned that is anchored to the posterior abdominal wall. The blood supply to the small intestine comes from different sources. For the duodenum, it has dual blood supply. Arterial supply comes from the celiac trunk and superior mesenteric artery. Usually, the celiac trunk gives rise to the gastroduodenal artery, and the gastroduodenal artery will give rise to the superior pancreatical duodenal artery. So, superior pancreatical duodenal artery supplies the duodenum and comes from the celiac trunk. The superior mesenteric artery whereas also gives supplies to the duodenum. The superior mesenteric artery gives rise to the inferior pancreatical duodenal artery. So the superior pancreatical duodenal artery supplies the proximal part of the duodenum, and then the inferior pancreatical duodenal artery supplies the distal part of the duodenum. The reason for this is because of the different origin points for each of these different aspects of the duodenum. So the proximal part of the duodenum is the part of the duodenum starting from the first portion of the duodenum all the way to the point where the major duodenal papilla tends to enter into the duodenum. So that area where we have the major duodenal papilla entering serves as a marking point distinguishing the proximal duodenum from the distal duodenum. So anything above the major papillae is the proximal duodenum. So proximal duodenum, like I said, is supplied by celiac trunk, largely from the superior pancreatical duodenal artery. Anything below the duodenal papillae is known as the distal duodenum and is supplied by the superior mesenteric artery directly from the inferior pancreatical duodenal artery. For the jejunum and the ileum, the blood supply tends to be straightforward. The jejunum is supplied by the superior mesenteric artery through what we call jejunal arteries. The ileum is supplied by the superior mesenteric artery through what we call the iliac arteries. What we need to note about each of these arteries, and that's the arteries supplying the jejunum and the ileum, is the fact that the iliac arteries and the jejunal arteries tend to form what we call loops or arches or what we call arterial arcades. So the arteries tend to anastomose or unite together, forming an arcade. And the arcade will give off small branches, what we call straight arteries, that would supply the jejunum or the ileum. These small straight arteries are known as vasa recta. So if you take a look at this picture, you notice that within the mesentery of the jejunum and the ileum, we have this arterial network of vessels. This arterial network of vessels that I'm outlining are the arterial arcades of the jejunum and the ileum. So these are the arterial arcades, and from the arterial arcades, we can see these short straight arteries that are moving towards the jejunum and ileum to supply them. So these short straight arteries you see moving towards the jejunum and ileum would be called or is known as the vasa recta. There are a few differences between the vasa recta and the arterial arcades that we see in the jejunum and ileum, and that's just important to note. Within the jejunum, the arterial arcades in jejunum are less and simple in terms of their network, and the vasa recta tends to be longer, whereas within the ileum, the arterial arcades in the ileum tends to be more complex. They are more complex and more in number, numerous in number, more complex, and they have a shorter vasa recta. So the vasa recta in the ileum is shorter, vasa recta in the jejunum is longer. The arterial arcades in the jejunum simple and less. The arterial arcades in the ileum is complex and more. The venous drainage of the small intestine is also very straightforward. The duodenum is drained by the hepatic portal vein and the superior mesenteric vein, whereas the jejunum and the ileum is drained both by the superior mesenteric veins. In terms of lymphatic drainage, there are various lymph nodes involved in draining the small intestine. For the duodenum, we have four major lymph nodes that drains the entire duodenum. This includes the pancreatical duodenal lymph node, the pyloric lymph node, the superior mesenteric lymph node, and the celiac lymph node. For the jejunum, we have four major lymph nodes involved in draining lymph from the jejunum. These include the juxta intestinal lymph node, the mesenteric lymph nodes, the superior central lymph nodes, and the superior mesenteric lymph nodes. And finally, in the ileum, we have five major lymph nodes that are involved in draining lymph from the ileum. These include all the lymph nodes that we saw that drains the jejunum alongside the ileocecal lymph node. So we have the juxta intestinal lymph nodes, the mesenteric lymph nodes, superior central lymph nodes, and the superior mesenteric lymph nodes alongside the ileocecal lymph node. Finally, to end on the gross anatomy of the small intestine, let's talk about the nerve supply. The nerve supply of the small intestine tends to be divided into that forms the celiac plexus and nerve forming the superior mesenteric plexus. Each of these nerves tend to contain both parasympathetic and sympathetic components. For the duodenum, we have dual innervation coming from the celiac plexus, which innervates the proximal part of the duodenum, and the superior mesenteric plexus innervating the distal part of the duodenum. Whereas in the jejunum and the ileum, we have just the superior mesenteric plexus supplying the jejunum and the ileum, and both um, contains the combination of sympathetic and parasympathetic nerves. Let's move on to the histology of the small intestine. So the small intestine is made up of a lumen of variable diameter and a wall surrounding that lumen. Now, this wall is made up of four main layers of tissue. This includes the mucosa layer, which is the innermost layer of the small intestine, followed by the submucosa, followed by muscularis externa, and then finally we have the serosta. Let's talk briefly about the mucosa layer of the small intestine. This is the innermost layer of the small intestine. It is composed of three major sublayers. This includes the epithelium, lamina propria, and the muscularis mucosa. The epithelium of the mucosa layer of the small intestine is lined by a simple columnar epithelium. So when we cut a sample of the small intestine and look into the interior aspect, we will see the mucosa being arranged macroscopically in a fold fashion, and these folds tend to be called plaques secularis. So plaques secularis are just the folds of the mucosa of the small intestine that gives it an increase in surface area. Another name for the plaques secularis, in case we don't want to call it that, we tend to call it the valves of Keckerings or the valvulae conniventi. So those are just other names which we call the plaques secularis. If we take the chunk of the mucosa and stain it and look at it under the microscope, we'll notice a number of features microscopically that we don't see in the mucosa of any other aspect of the GIT. So microscopically, the mucosa of the small intestine contains projections known as the villi. So villi are outward projections of the mucosa. And the reason for this is also the reasons why we have plaques secularis is to increase the surface area of the small intestine. The villi tend to be those projections and have spaces in between them. So the spaces or the depressions between the villi are known as crypts of Lebercon. So if you notice, one projection villi is separated from another projection of villi by a space, and this space is known as the crypt of Lebercon. So the villi and the crypt tend to contain a number of cells that are involved in the functions of the small intestines alongside the absorption. So each villi, let's focus a bit on the villi. Each villi of the small intestine has a connective tissue core that extends from the lamina propria and contains a large amount of fibroblasts, smooth muscles, and lymphocytes, alongside the plasma cells, and capillaries, and a central lymphatic vessel known as lacteal. So that's a mouthful. What you just need to note is that within the villi is an extension of the lamina propria, and that extension contains a number of tissues, cells, and vessels. The vessels that we tend to see there, we see capillary network, which includes arterial or arteriolar network and venous network, combined to form a capillary. And then, most importantly, we see a lymphatic network found there. That lymphatic network is known as the lacteal. And alongside that, we have some other cells like fibroblasts, small muscles that we tend to also see in the lamina propria. And that's the unique aspect of the villi or the villus of the small intestine that we need to remember. Let's talk about the cells that tend to line the villi and the crypt. This includes a number of cells, about eight of them. They are the enterocytes, goblet cells, the stem cells, the Paneth cells, I cells, S cells, D cells, and then the enterochromaffin cells. Each of these cells have different functions. Talk about each of them one by one. So let's start with the enterocyte. The enterocytes tend to line both the villi and the crypts. They are tall columnar cells that have an oval nucleus at their base, and they have an apical and basal portion. Apical end of the enterocytes tend to contain microvilli. So the enterocytes are found on the villi, but the cells themselves have also their own projections known as microvilli. If you notice, this tiny projections that you're seeing on the cells, yeah, these projections, tiny projections are known as microvilli, just extensions of the plasma membrane and cytoplasm of the cell. As a result, this microvilli that is present on the enterocyte tend to be described as brush borders, and it's important for absorption. Remember that's the whole reason why we have the plaque secularis, why we have the villi, and now why we have the microvilli or brush border in the enterocyte within the small intestine is the process of increasing surface area, and that surface area is increased for the purpose of absorption of nutrients within the small intestine. So the major cell involved in absorption of nutrients is the enterocytes, and that's the reason why they contain the microvilli. And we have the goblet cells. Goblet cells tend to also line the villi and the crypts. They secrete mucus substances or mucus secretions that helps in protecting and lubricating the intestinal lining of the small intestine, and that's very important because some of the contents that comes from the that is received from the stomach tend to be acidic, and as a result, mucus, especially mucus containing a large amount of bicarbonate, would need to be produced to neutralize the acidic contents coming from the stomach. The third cell found in the small intestine would be the stem cells. Stem cells tend to be found within the crypt. They are cells that tend to produce progenitor cells of all other epithelial cells within the small intestine. So they are involved in producing every other cell. They are kind of progenitor cells for to the rest of the cells found within the small intestine. Fourth cell is the Paneth cell. Paneth cell tends to lie at the base of the crypt of the small intestine. They are important in secretion of very important proteins slash enzymes. So enzymes, proteins like defensins, lysozymes, and the phospholipase A2 are produced by the Paneth cells. And these are important proteins slash enzymes in the function of innate immunity within the small intestine. Then we have the eye cells. The eye cells are tend to line the crypt. They secrete cholecystokinin. That's a very important substance or hormone involved in the process of the production or release of bile. I largely involved in the release of bile than the production. Cholecystokinin tends to act at the gallbladder and helps in contraction of the gallbladder for the production or the release of bile into the duodenum. Then we have the S cells. The S cells also lines the crypt, produces secretin. Secretin is involved in the production of bile. So while um, cholecystokinin is involved in the release of bile, secretin is largely involved in the production of bile. Then we have the D cells. The D cells line the crypt as well, and they also extend all the way, or they are rather largely exclusively located in the duodenum. So if you remember, D stands for duodenum. Remember that these cells are only found within the duodenum. They secrete somatostatin, and somatostatin tends to be a form of inhibitory hormone that inhibits most of the other hormones that we see. Hormones like cholecystokinin and secretin are inhibited by somatostatin. Besides that, hormones that we see being produced within the stomach, like gastrin and histamine, also tend to be inhibited by somatostatin. So it's more of an inhibitory hormone when it comes to the aspect of the small intestine that deals with endocrinology. The last cell in the small intestine is the enterochromaffin cells. Enterochromaffin cells tend to line the crypt, and they are also involved in the production of serotonin. The second layer of the small intestine is the submucosa. It is the layer that lies just directly beneath the mucosa layer. It's composed of dense connective tissue that has collagen, elastic fibers, blood vessels and lymphatic vessels within it. Aside this, the one major important structure found within the submucosa are specialized nerve tissues known as Meissner's plexus or submucosal plexus. These plexus are involved in the process of stimulation of the glands of the submucosa in the production of in large amounts of mucus secretion. These glands are known as the is known as the Brunner's gland. So the Brunner gland is found largely in the duodenum. We have some other glands, tubular glands found in the jejunum and ileum, but the one we see in the duodenum is known as the Brunner's gland. The ileum in the submucosa of the ileum contains a large amount of lymphoid aggregates known as Peyer's patches. Those are just important distinctions between the ileum, the duodenum, and the jejunum. All of them will contain a Meissner's plexus within their submucosa, but the duodenum has Brunner's gland that is unique to it. The ileum has the Peyer's patches that is unique to it. Let's move on to the muscularis externa. This is the thickest and third layer of the small intestine. It contains two layers of muscles. These are the inner circular muscles and the outer longitudinal muscle. These muscles are involved in reducing peristaltic movements of the small intestine and allowing for the propulsion of food or of nutrient content from the stomach or small and to the small intestine, and then from the small intestine towards the large intestine. The muscularis externa, just like the submucosa, also contains specialized nerve tissue. The nerve tissue we find in the muscularis externa is known as the albus plexus. It is found between the two layers of the muscles found in the muscularis externa. Both the albus plexus and the Meissner's plexus together would form the enteric nervous system of the small intestine. Last layer of the small intestine is the serosa. It's the outermost layer composed of largely um, largely mesothelial tissues, so which is majorly simple squamous epithelium, and that lines it. So here is a table that outlines for us the summarized portions of the histology of the small intestine. So in terms of the histology, remember that the small intestine is made up of four major layers: the mucosa, the submucosa, the muscularis externa, and the serosa. The duodenum contains the all of them contain simple columnar epithelium. The duodenum tends to contain a spatula-shaped villi, or the crypt of Lebercon is also found there, and then microvilli on the enterocytes. The submucosa and the duodenum contains blood vessels, lymph vessels, Meissner's plexus, and very importantly, Brunner's gland, which is exclusive to the duodenum. The muscularis externa is made up of the inner and outer muscles alongside the albus plexus and which between them. And then we have the serosa layer, this is the outer layer of the duodenum that contains mesothelium of the visceral peritoneum. The jejunum, in contrast, is also lined by simple columnar epithelium. The difference between that and the duodenum is the fact that the villi of the jejunum tends to be larger, and tends to be leaf-like in shape. It also contains the crypt of Lebercon and microvilli in its enterocyte. In the jejunum, the submucosa contains blood vessels, lymph vessels, and Meissner's plexus. It doesn't have the Brunner's gland. However, it has large amount of glands that are also unique to it, but are not necessarily Brunner's gland, and also contains large amount of lymphoid tissues that are not necessarily Peyer's patches, as we see in the ileum. The muscularis externa of the jejunum is similar to that of the duodenum alongside the serosa. For the ileum is also lined by simple columnar epithelium, just like the other two. It has the its villi being less and shorter. The plaques circularis, I didn't mention, it's more prominent in the jejunum than the other two. But in terms of the microvilli, and in terms of the villi, rather, the villi that we see in the ileum is less and shorter. It is finger-like in projection. The ileum also contains the crypt of Lebercon and microvilli in its enterocytes. In the submucosa of the ileum, we have blood vessels, we have lymph vessels, we have Meissner's plexus, and very unique to it exclusively, we have the Peyer's patches. The muscularis externa and the serosa of the ileum is similar to that of the jejunum and the duodenum. Let's end this module by talking about the embryology. We'll talk about the embryology of the duodenum, and then we'll focus on the embryology of the jejunum and the ileum finally. The duodenum tends to develop partly from the foregut and partly from the midgut. The caudal part or proximal part of the duodenum, that part that is proximal to the major duodenal papilla is derived from the caudal part of the foregut, whereas the distal part of the duodenum, the part that is below the major duodenal papilla, is derived from the cranial part of the midgut. The caudal part of the duodenum tends to begin developing at the fourth week, whereas the distal part tends to begin developing at the sixth week of intrauterine life. During the fourth week, the duodenum begins to develop from the those two major aspects alongside splanchnic mesenchyme. So it develops from the caudal part of the foregut and the cranial part of the midgut, and then portions of it will be derived from the splanchnic mesenchyme. The developing duodenum grows rapidly and then forms that C-shaped loop that I mentioned in terms of its gross anatomy. And as the stomach tends to develop and rotate, the duodenum tends to rotate alongside the stomach. So remember that the stomach tends to rotate in a clockwise direction. So as the stomach is rotating clockwise, the duodenum also tends to rotate clockwise. So the duodenal loop rotates to the right, and after rotation, it becomes pressed by the anterior wall of the abdominal cavity and becomes retroperitoneal as a result. So now, the duodenum tends to start off as an intraperitoneal organ, but after rotation and it's the and becomes pressed to the posterior abdominal wall, it becomes retroperitoneal. So we usually say it's a secondary retroperitoneal structure because it was initially intraperitoneal but eventually became retroperitoneal. During the fifth and sixth week of development, the lumen of the duodenum tends to undergo a very large amount of proliferation of cells, and this narrows the lumen and automatically obliterates it. So the obliteration of the lumen occurs temporarily, and then by the ending of the embryonic period of development, the duodenum now undergoes recanalization, in which the lumen automatically becomes patent once more. And this is very important because if there's a failure of recanalization of the lumen of the duodenum, this could either lead to a common anomaly known as duodenal atresia or duodenal stenosis, depending on the extent. We'll talk about that at the ending of this model. Let's end with the derivatives of the duodenum. The caudal part of the foregut that forms the duodenum becomes the first and second part of the duodenum. The second part of the duodenum specifically above the major papillae, whereas the cranial part of the midgut that forms the duodenum will become the second part of the duodenum, the third part of the duodenum, and the fourth part of the duodenum. All these parts are usually below the major papillae. Let's move on to the development of the jejunum and the ileum. These develops from the cranial limb of the midgut at the sixth week of intrauterine life. As the midgut tends to develop, it elongates and then it forms a ventral U-shaped loop of guts, and this is known as the midgut loop of the intestine. Because of the excessive length and size of the midgut during development due to its elongation, it starts to leave the entire abdomen and enters into the umbilicus. And usually, as it does that, it undergoes a number of processes or changes from the sixth week down to the 10th week of development. And this is usually characterized in four major phases. This includes the phase of herniation, phase of rotation, phase of return, and then finally the phase of fixation. So the first phase of the development of the duodenum and the ileum is known as herniation. Herniation, as I said before, occurs as a result of the elongation of the midgut loop. This elongation tends to outpace the expansion of the abdominal cavity. So because the midgut loop is larger in terms of length compared to or relative to the size of the abdominal cavity, the midgut then eventually would herniate into the umbilical. So this herniation occurs through the primitive umbilical ring into what we know as the extraembryonic cilium. This herniation is known as a physiologic herniation. That's very important to remember. This is different from herniations that we see after birth, known as pathologic umbilical herniation, in which the midgut loop or the midgut at this point is still present within the umbilicus and has failed to return back into the abdomen. While within the umbilicus or an umbilical cord, the midgut loop begins to rotate and tends to rotate about 90 degrees counterclockwise while within the umbilicus. This rotation is usually done at the axis of the superior mesenteric artery, and that's very important to note because if there's a problem with rotation, if the rotation is abnormal, it could lead to abnormal rotation along the axis of the superior mesenteric artery, and that can compromise the artery, and that can lead to a damage to the superior mesenteric artery and the structures in which it supplies. So the rotation that occurs, this 90 degrees counterclockwise or anti-clockwise rotation, will bring the cranial limb of the umbilicus, brings it to the right, and the caudal limb brings it to the left. Usually the cranial and caudal limb tends to be just superior and inferior. So we have that once we have that 90 degrees rotation, the cranial limb would automatically be placed on the right, and then the caudal limb would automatically be placed on the left due to the 90 degrees rotation. Remember that it's a counterclockwise rotation, so it's occurring like this. So cranial becomes right, caudal becomes left. So at about the 10th week, the midgut loop begins to return into the abdomen. So this return tends to occur in a very unique fashion because within the abdomen, remember that the midgut loop tends to rotate 90 degrees counterclockwise. So as it returns into the abdomen, it also undergoes a similar form of rotation. So as it returns into the abdomen from the umbilical cord, it rotates also counterclockwise, but rotates about 180 degrees counterclockwise. So in total, we say that the entire midgut loop rotates about 270 degrees counterclockwise during its entire development phase. This rotation and return it's unique because the adult derivative of the midgut loop tends to be positioned the way in which it is due to the return and rotation that occurs. So during the return, the cranial limb, which is our major focus, because the cranial limb gives rise to the jejunum and the ilium, returns first, and then it passes posterior to the superior mesenteric artery, and then eventually occupies the central portion of the abdomen. And that's the reason why we have the jejunum and the ilium in the center of the abdomen. Once the cranial part of the midgut has entered into the abdomen, it tends to retain its mesentery. The mesentery is at first attached to the median plane of the posterior abdominal wall, but with time it would automatically form this span-shaped mesentery that and acquires a new alignment and passes from the duodenal junction inferiorly to the idiosical junction. So the mesentery tends to expand in size, and then it tends to encompass the entire length of the jejunum and ilium at the end of the day. So the reason why the jejunum and ilium tends to be intraperitoneal is because of the fact that they retain their mesentery. This is unlike the duodenum because remember during the development of the duodenum, after the duodenum has undergone rotation, it automatically becomes fixed to the wall of the posterior abdominal wall. Yeah, it tends to press on the posterior abdominal and becomes fixed and automatically becomes retroperitoneal. So that one does not retain its mesentery. So unlike the jejunum and ilium, fixation does not really occur. Or instead of fixation occurring, what occurs is that mesentery is retained, and then mesentery tends to expand from the jejunal junction all the way to the vesical junction. This is in contrast to what occurs at the caudal end of the midgut. So the caudal midgut loop, on the other hand, tends to actually undergo fixation. So the caudal medical tube would give rise to the large intestine, and the large portion of the large intestine tends to be retroperitoneal because after the caudal midgut loop enters into the abdomen, it becomes fixed to the posterior abdominal wall, just like the duodenum. We don't say that in the jejunum, whereas in the jejunum there's retainment of the mesentery, and that makes the jejunum and the ilium to be intraperitoneal. So that's the derivatives of the midgut loop. The cranial limb of the midgut loop, like I said, gives rise to the jejunum and the ilium. The caudal part, although not shown in the slide, would form the large intestine. Let's end by talking about some clinical significances. This includes that of the anomalies like duodenal atresia, stenosis, like I mentioned, then the Kel's diverticulum. We'll talk about that very soon. Omphalocele, gastroschisis, and umbilical hernias. So duodenal atresia or stenosis tends to occur whenever there's a problem or issue with the duodenum in development. So when there's a failure of the lumen within the duodenum to recanalize, that could either lead to duodenal atresia or duodenal stenosis. Usually, duodenal atresia tends to occur at the second and third part of the duodenum. Duodenal stenosis tends to occur at the third and fourth portion of the duodenum. And usually, this tends to eventually lead in the child is that the child will have difficulty feeding. Whenever we feed the child tends to undergo villous vomiting. So the child will vomit contents of food that contains bile, and this is because of the fact that just directly close to the portion of obstruction of the duodenum is the major is the major duodenal papillae where the ampulla obverta would release bile into the duodenum. So when there's an obstruction below that point, below the, let's imagine the obstruction is occurring below the major duodenal papillae. Whenever the child feeds, the food is mixed with bile at this point, and due to the obstruction, the food cannot no longer go all the way down to the jejunum, and then we have that retrograde peristalsis occurring, and the child will expel all the food out through the process of vomiting. The most common anomaly that we see during the development of the entire small intestine is known as the Meckel's diverticulum. The Meckel's diverticulum is an outpouching that we see at the ileum, usually at the anti-mesenteric border of the ileum. That's the border that is not connected to mesentery. And this usually occurs whenever there's an abnormal connection between the 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 ileum and the yolk sac through the Vitellins duct. Usually, there's usually typical connection between the midgut loop and the yolk sac through the Vitellins duct. But with time, Vitellins duct is meant to be obliterated and is meant to disappear. But whenever there's a failure of obliteration of the Vitellins duct, usually if the failure of the obliteration is very close to the ileum, this will lead to that outpouching we know as the Meckel's diverticulum. Very importantly, there are two. There's a rule of twos with regards to the Meckel's diverticulum. This rule of two states that um 2% of population tend to experience Meckel's diverticulum. In terms of male female predisposition, is two times more common in males than females. The outpouching itself, the Meckel's diverticulum itself, is about 2 feet from the ileocecal valve. In terms of length, is about 2 inches in length. In terms of development, it has two major complications uh, due to the fact that there are two major types of tissues that are found there. One of them is a gastric tissue, the other is the pancreatic tissue. And then 2% tend to also develop complications, about 50% before the age of 2. Let's talk about two important anomalies that we see within the small intestine and its development. This is known as gastroschisis and omphalocele, and this occurs whenever we have an abnormal sighting of both of the small intestine within the abdomen. One of which is a scenario where we have the entire small intestine loop being out and not covered by any form of membrane or tissue, and that's known as gastroschisis. The other is a similar scenario, but we have a sac that tends to cover the entire small intestine. That's known as omphalocele. So gastroschisis tends to be due to a defect in the anterior abdominal wall. So whenever there's a defect in the anterior abdominal wall, the small intestine is going to be present outwards. And gastroschisis does not contain a sac. There's no sac covering the small intestine. So the small intestine is just already out. It tends to be seen in children that are prematurely born. The umbilical cord tends to be present, and it's just at the side of the the exit point of the gastroschisis. So this is the umbilical cord present here, and it's just by the side of the site where the gastroschisis is occurring. The Besides that, the viscera tend to, and aside the small intestine, the stomach could also be a viscera emanating through the defect in the wall of the abdominal cavity, and then the colon as well could be also involved. Gastroschisis tend to be related to malrotation. Then how have it for malrotations occurring with gastroschisis, and that can lead to compromise with the small intestine, and that would probably lead to incarceration, and we will need to remove the part of the small intestine that has been affected. This could also present with inflammation and edema of the small intestine. Usually, enteral nutrients tend to be delayed. We don't want to start feeding the child because the intestines are out until we get them in fully and we stabilize them before we can start feeding. And finally, it is not really associated with other anomalies. Then it tends to usually occur just by itself. Usually, if it's going to occur with an anomaly, it tends to occur with an atresia. For omphalocele tends to be normally that occurs on the umbilicus itself. So it occurs through the umbilicus, not at the site. It is always covered by a sac. Usually, the sac contains peritoneum, Wharton's jelly, and an amniotic membrane. So, amniotic membrane, Wharton's jelly, and then peritoneum covers the entire sac of small intestine. That forms the omphalocele sac. The type of kids that we tend to see with that are usually kids that are born term, Um, Aside that, the viscera are then to be herniating together with the small intestine could either be stomach, the colon, or the liver. We also tend to see malrotations together with the with together with gastroschisis. So we see malrotations occurring in omphalocele as well. But we don't see inflammation or edema because remember that this small intestinal loop and the other viscera they are covered by the sac, and sac serves as a form of protective covering for the herniated viscera. Then enteral feedings could be initiated in children with amphotericin because the small intestine are not necessarily at risk of inflammation or edema. And then we tend to see amphotericin with a number of other anomalies. Usually 50% of the time, amphotericin is occurring with other anomalies alongside itself. The last of the this particular anomaly is known as umbilical hernia. This is really an asymptomatic anomaly in which we have the physiologic hernia that has occurred during development of the jejunum and ileum failing to return back. So remember that we had that four phase: inhalation, rotation, return, and fixation. Whenever we have failure of the small intestine to return back fully into the abdomen, then we have an umbilical hernia. So that is really depicted by a large umbilical or large umbilicus in a child. And if you palpate the umbilicus, you feel the softness of the ball loop within the umbilicus. This is really asymptomatic. It is not necessarily a problem as compared to that of gastroschisis or omphalocele. And usually the umbilicus tend to return eventually into the abdomen. And that concludes our module on the small intestine.